Hello everyone. Today we're going to go over high risk postpartum and the high risk neonate. One of the first things I want to discuss is the risk reduction for postpartum complications. So while the riskiest component of a delivery or of giving birth is during the labor process or potentially during a cesarean section, there are several complications that can occur in the postpartum setting, and we will be discussing some of those right now. So some of the risk reductions would be to definitely review the prenatal and the intrapartum records. All right. So prenatal, why do we need to know prenatal information? Because the prenatal record gives you a wealth of information. You'll know whether mom was positive for GBS, if she has any possible STI, if she was compliant with her prenatal, vitamins and whatever medication she needed to be on. For example, if the mother has herpes, was she on a cyclovir and for how long and when did it stop or did it even stop, right? So it gives you a wealth of information. In addition to that, it's important that we review the intrapartum records. Why? For risks such as anemia, a long labor, an operative vaginal delivery, which is going to help you. Having this knowledge is going to help you to have to anticipate any possible complications. For example, if your patient had an operative vaginal delivery and the physician utilized forceps, you have to know that there's a possibility that maybe there's a laceration that the physician did not see. And so you have to monitor closely for bright red bleeding. Does she have a laceration? Okay. If your patient has anemia, and let's say she had a cesarean section, or you want to be able to look at the labs, whatever was collected when she came in to deliver the baby, to know where you need to be in the postpartum setting. Assessing for signs of postpartum complications and intervening appropriately. The key thing with prevention or risk reduction is early identification. Okay, so this is why we have to assess. In the first 24 hours, we generally assess every 4 hours. And more importantly, like I always say, you have to educate your patients so that they know what possible complications to look out for. It's also important that during the postpartum period that we get the women ambulating as quickly as possible. If it was a vaginal delivery, we want to make sure that she's ambulating right away. If, of course, once her epidural wears out, if she had an epidural, if we have a C-section, the minute she gains mobility and is able to, gain total strength in her legs, she should be out of bed and ambulating, all right? This will decrease the risk of DVT, which is huge because we know that women are in a hypercoagulative state at this point, right? We also want to prevent an overdistended bladder. We know that an overdistended bladder can cause uterine atony. How does that happen? When your bladder displaces the uterus, it shifts to the side and the uterus becomes boggy. When the uterus becomes boggy, what happens? We bleed out. So we want to make sure that we monitor the bladder. Important to have good hand washing techniques, not just by the healthcare provider, but to teach the patients and the visitors, particularly now with COVID, but more importantly, because if the patient is going to be touching her incision, if she's going to be, changing her pads, you want to make sure that that her hands are clean before she starts touching anything that's going to go in the perineum, particularly if she does not have an intact perineum. And then, of course, you want to make sure to promote appropriate diet, fluids, and activity, as well as rest. Remember, mom and dad are tired after the delivery. We have to learn to cluster care to provide for rest of the new mom and dad. Even if it's not their first baby, they might not be new parents, but it's important that we provide time for them to be able to recover from the labor process. With hemorrhage is a huge complication in the postpartum setting, and it is more common than we think. Okay, postpartum hemorrhage is basically blood loss greater than 500 mLs for vaginal delivery or greater than 1,000 mLs for a cesarean delivery with a 10% drop in hemoglobin and or hematocrit. This is why it's important that we look at our patient's prenatal record, that we look at their intrapartum records and see what was her hemoglobin like before, what was her hematocrit like before. Is she hemorrhaging? What are we looking at here? When you draw labs because you suspect a patient is hemorrhaging, you want to take a look at that. Has it been a 10% drop? Okay, patients with postpartum hemorrhage are basically using a two-system approach. First of all, you want to provide resuscitation and management of the hemorrhage and potential hypovolemic shock, and then you want to identify the underlying cause. All right, so for example, if my patient is hemorrhaging and she becomes hypovolemic or starts having signs of hypovolemia, I want to probably give her a bolus of fluids. However, my next step has to be to identify where is she bleeding from, what is causing the hemorrhage, so that I can, eliminate the root cause of the problem. When we perform quantification of blood loss, this means we no longer do EBL, which is a visual estimation of the blood. We actually want to weigh the soiled pads, the soiled linens, soiled socks, whatever gets soiled with blood, we want to weigh it to be able to quantify the blood loss. 1 gram of blood loss is 1 ml is equivalent to 1 gram. Okay, so keep that in mind. We also want to talk about examples of threshold parameters. Okay, we have what we called a red trigger, which means you need to take action immediately. Okay, you need to be at the bedside and be evaluating your patient right away. Then we have what we call a yellow trigger, which means that you require further clinical evaluation, but it is not as critical as a red trigger. Okay, so we're looking at, for example, if you look in the critical component, you'll know the temperature range, okay? It's going to be extreme. Blood pressure, if you have systolic blood pressure greater than 160, or a diastolic blood or systolic lower than 90, these are all little flags that we need to look at. The heartbeat, is your patient tachycardic? What is going on? And the respiratory rate is also important that we looked at. And then, of course, the O2 sat should always be 95 or greater. Then we have what we call the 4 T's, precipitating factors of hemorrhage. The first T is the tone, uterine tone. If we have uterine atony or a boggy uterus, we have an array of complications that can occur. Okay, what can cause uterine atony? A large baby, high parity, rapid labor or precipitous labor. If mom has fever or if they have uterine fibroids, they're more likely to bleed. What are you going to see? In addition to maybe a steady or profuse bleeding, you're going to have a large, larger than expected uterus and a boggy uterus. And when you look at the lochia, you might see clots. All right, so we want to monitor these patients, and we don't want a patient with uterine atony. We have to intervene. You want to make sure that you maybe do vital signs frequently, that you get a blood type and screen, that you maybe monitor or set aside 2 units to be able to infuse or transfuse your patient if necessary. You may want to insert an IV Foley to make sure that the bladder is empty, because we know, again, a full bladder can displace the uterus and cause uterine atony. Then we have tissue, that's the second T, which means retained placenta or an abnormal placenta. When the placenta is retained, when we have retained placental tissue, we also increase our chances of not just infection, but also uterine, like hemorrhaging. And then trauma is another precipitating factor of hemorrhages. Does she have a laceration? Again, this is why we go back to being able to understand or know what happened in the labor process. Does she have an operative vaginal delivery? We got to keep an eye for that T, the trauma. Hematoma, the patient might have a vulvar, vaginal, cervical, or retroperitoneal hematoma, where you're not going to see the pad soaking through, but the patient might experience a bulging area right underneath the skin, difficulty voiding or sitting. They'll feel like pressure in the perineal area. And a lot of times they will express wanting to use the restroom, wanting to have a bowel movement. And it could be due to a hematoma. The fourth T is thrombin disorders. We have to monitor closely patients with preeclampsia or patients who have a stillborn baby, because they can develop serious complications like DIC, disseminated intravascular coagulopathy. If this occurs, you're going to see oozing from the IV sides. They'll be bleeding from a lot of orifices. Sometimes they get nosebleeds, petechiae, bleeding from the gums, and then of course signs of shock that we have to look out for. Indications of primary postpartum hemorrhage, okay, which I'm going to talk about. What is primary? Primary postpartum hemorrhage is basically bleeding or hemorrhaging that occurs within the first 24 hours after childbirth, all right? And it can be caused by uterine atony, lacerations, or hematomas. Then we have what we call secondary postpartum hemorrhage. This occurs 24 hours after the delivery and up to 6 weeks post-delivery. In fact, it can even occur up to 12 weeks, all right? And it can also be caused by hematomas, subinvolution of the uterus, retained placenta tissue, etc. So it's important that we keep that in mind. What are some indications of primary postpartum hemorrhage? Remember, how do we know it's primary? 10% decrease in the hemoglobin or hematocrit, okay, post-birth. Saturating pads every 15 minutes. The fundus remains boggy, all right? You must do a fundal massage. Your patient can become tachycardic. Please note, this is a late sign. When your patient is tachycardic, they are trying to compensate for so much blood loss. So this is a late sign. And then, of course, decreased blood pressure, which is also a late sign. They're probably going into shock. So it's important that we keep that in mind. Uterine atony, like I said earlier, is basically decreased tone in the uterine muscles, and it is a major cause of postpartum hemorrhage, so we need to keep that in mind. What are you going to find in uterine atony? A soft, boggy uterus, saturation of peripads every 15 minutes, or you could have a slow and steady or sudden massive bleeding. You have the presence of clots. The patient's going to look pale and clammy. They might be anxious and confused. Again, tachycardia and hypotension, which are late signs. All of this is not because the uterus is because you have uterine atony. It's because the uterine atony is causing hemorrhage, okay? So it's important that we know that. You have to make sure that you have in stock in a postpartum setting, we always do, medications to use in active bleeding like oxytocin, methergin, misoprostol, carboprost, and anything basically uterotonics that'll help to contract the uterus. These can be used after expulsion of the placenta, right? We can also do bimanual compression of the uterus per the provider, okay? And then we want to increase the fluid that, not necessarily oxytocin, although we will give them additional oxytocin, but just fluids in general to decrease the chances of hypovolemia. All right, you want to give them either normal saline or lactated ringers. Fundal massage. Remember when we're doing a fundal massage that we are to support the lower segment of the uterus. Then we have with uterotonics and Pitocin, we want to make sure that, that we have a good IV in place and that the oxytocin is infusing as per doctor's orders. With methergin or methylergonovine, we need to make sure that we know that it is contraindicated in patients with hypertension. So contraindicated in hypertensive patients. With carboprost, also known as hemabate, it also helps to contract the uterus. And then misoprostol cytotec, it does the same thing. It is to control postpartum hemorrhage. And it's actually an off-label use, okay? But it is very effective in contracting the uterus. With lacerations, lacerations can occur in the cervix, in the vagina, the labia, or the perineum. And it can occur, obviously, during childbirth, or it can be secondary to an episiotomy. It can be an extended episiotomy depending on what happened with the patient. This usually occurs when they have large babies or they have an operative vaginal delivery, either with forceps or a vacuum extraction, or when we have precipitous labor because the soft tissue in the birth canal doesn't have time to gently stretch. Okay, remember precipitous labor occurs within 3 hours, and so everything goes really, really fast. and there are more chances of developing lacerations. So we always want to make sure that the physician inspects for possible lacerations, and if we see trickling of bright red blood, we have to suspect that she might have a cervical or vaginal laceration and must be repaired. Hematomas, I think I spoke a little bit about that already. We just have to make sure that we know that if a woman is complaining of severe vaginal or perineal pain and they can't put pressure, or they start getting tachycardia and hypotension and you don't see the actual bleeding, you have to suspect a hematoma. Subinvolution of the uterus is another cause for hemorrhaging, and it's basically when the uterus doesn't involute as expected. Subinvolution of the uterus can occur in women who have fibroids or endometritis, or who have retained placental tissue. So again, it's important that we assess the lochia. Do we see placental tissue? Is she, are you expressing a lot of clots? In serious situations, a lot of times the patient has to go to the OR for a DNC to remove the retained placental tissue. We give methergine PO for fibroids, and then antibiotic therapy is initiated to prevent endometritis. Okay, or treat it if the subinvolution is being caused by endometritis, which is an infection of the endometrium. Then the retained placenta can cause profuse bleeding, like I said, subinvolution of the uterus. Your patient will be pale in skin color. Remember, tachycardia and hypotension are late signs. We want to make sure that we administer antibiotics, and that if necessary, we might have to do a DNC. Another complication that we can see in the postpartum setting are coagulation disorders. The biggest one, well, there's several, but one of the things that is most concerning is disseminated intravascular coagulation, or DIC. All right, this is the syndrome in which the coagulation pathways are hyperstimulated. Basically, this occurs when the body is breaking down the clots a lot quicker than it is forming them, and therefore the woman starts hemorrhaging. They literally start bleeding from the IV site, from their nose, from their gums. They get petechiae in the face, everywhere. So some of the risk factors or things that can lead to DIC are an abruption placenta, because the patient loses an incredible amount of blood. And when you start losing all these clotting factors, your body, again, is breaking down the clots a lot quicker than it can form them. We know HELLP syndrome. HELLP syndrome is hemolysis, elevated liver enzymes, and low platelets. When you have low platelets, again, you run the risk of developing DIC. Anaphylactic syndrome of pregnancy. We know what that is. It's an amniotic fluid embolus. This is also a risk factor for developing DIC, as anaphylactic syndrome of pregnancy gets complicated. And then, of course, any kind of hemorrhage, if it is not resolved, if it is not contained, can lead to DIC. Knowing your patient, understanding their prenatal record, and knowing what labor was like for this patient is critical in early detection of DIC and being able to address it quicker. With anaphylactoid syndrome or an amniotic fluid embolus, please know it is very rare, but it is often, quite frequently, fatal. And it can occur while the woman is pregnant, once membranes are ruptured, during labor, during birth, or even up to the first 24 hours post-birth. It's a two-stage process, and basically, remember I told you the amniotic fluids with fat cells, lanugo, vernix, and all of this junk enters into the vascular system, and it leads to cardiorespiratory collapse and ultimately DIC. All right, women usually die within a few hours of the symptoms onset. So again, it is important that we're able to diagnose this, or you can't really diagnose it, but if you suspect it, if your patient all of a sudden becomes short of breath, she starts seizing, she's hypotensive, cyanotic, she goes into cardiopulmonary arrest, massive hemorrhaging, cardiac and respiratory arrest, you have to know that these are signs and symptoms. If nothing else is going on, your patient is experiencing an amniotic fluid embolus. So we need to be able to identify these findings when we're assessing a patient who maybe lost consciousness. She was talking 1 minute and all of a sudden lost consciousness. You have to further investigate, and if your patient is ruptured, this is probably what's happening in that patient. Like I said, it is often fatal. Then, of course, we know about venous thromboembolisms. This is important that we get our patients ambulating, walking as quickly as possible to prevent DVT. Then we have infections in the postpartum period. All right, and this is like, it could be an array of things. The patient can have endometritis, or metritis is the same thing. And again, it's an infection of the endometrium, the myometrium, and or the parametrial tissue. Okay, and approximately 2% of women who experience a vaginal birth and 50% of women who experience cesarean birth can develop endometritis. Why? Why the difference in percentages? Because in a woman who does a vaginal delivery, yeah, we're doing vaginal examinations, but they're sterile and, it's going through the vagina and you have all kinds of things to fight bacteria in your body. However, in a C-section, when you're having a C-section, your entire abdomen is open, and no matter how sterile you want an OR room to be, it is not perfectly sterile. So your chances of developing endometritis when you have a C-section are a lot higher, 15% versus 2%. What are we going to find in women with endometritis? We're definitely going to find a temperature, elevated temperature, greater than 100.4 degrees Fahrenheit or greater than 38 degrees Celsius. They would have midline lower abdominal pain or discomfort. Uterine tenderness. So it's not the typical pain of the uterus being of the uterus contracting. The uterus is actually tender. All right. Tachycardia, you'll experience subinvolution. They have general malaise. Remember, this is an infection. Headache, chills. The lochia is very heavy, and very important, foul smelling when anaerobic organisms are present. Okay. Please note that foul smelling lochia is a later sign that occurs when the entire endometrium is involved. So when it smells, it's serious. When the lochia doesn't smell, but she has every other symptom, it means that the infection is due to a beta hemolytic streptococcus. Okay, we want to make sure that we watch CBC, okay? We're looking for WBCs that are greater than 20,000. The doctor may order endometrial cultures, blood cultures, urinalysis to rule out a UTI, which is also common in the postpartum setting. They're very common because of all the trauma the woman experiences during labor. If it's a vaginal delivery, for obvious reasons. And if it's a cesarean section, remember, they've had a Foley catheter or an indwelling catheter in place, which of course increases their chances of developing a UTI. You'll find a low-grade fever, burning upon urination, the suprapubic pain, urgency to void, and then they usually have small frequent voidings of less than 150 cc's per void. All right. We want to do a UA, CBC, urine culture and sensitivity, and we want to do this before we start administering antibiotics, which would usually be PO in the postpartum setting. We can also help reduce the chances of a woman getting a UTI if we remove the Foley catheter in a post-cesarean section patient as quickly as possible. As soon as she's able to gain mobility and maybe use a bedpan, we want to, remove the Foley. Another infection that can occur in the postpartum setting is mastitis, which is an inflammation and infection of the breast tissue. And this is more common in lactating women. Why? Because babies latch on, they're not latched on properly. Maybe the women wear like a wearing a tight fitting bra. The cracked and sore nipples where the baby suctions, bacteria can get into there. They might use the same position for breastfeeding, which prevents the emptying of the other breast. If a woman has poor nutrition, or when you have ample milk supply, but you are not breastfeeding enough, okay? So what are some of the assessment findings? Usually they have flu-like symptoms when we have mastitis, all right? Breast tenderness, warmth to the touch. They feel general malaise. They're swollen, hardened, pain, burning sensation, and again, a fever. These women need antibiotic treatment. So if they go home and they develop mastitis, this is one of the things that we teach them. If you see that your breast is red, and again, this is unilateral, by the way, this usually only occurs in one breast. Can it occur in both at the same time? Yes, the chances are, slim, but it can happen. So we want to educate our patients and let them know that if this occurs, if they develop all these symptoms, that they must contact their provider because they do require oral antibiotics. And of course, a wound infection can occur if a woman has a repaired laceration and episiotomy, or if they had a cesarean section. It is important that we utilize a septic technique throughout the delivery if she's having a vaginal delivery, and that we educate our patients on how to care for their incision after a cesarean section, or even how to care for an episiotomy or a laceration after they give birth to a baby. They should be changing their pad every time they go to the restroom. They should be doing peri-care every time they go to the restroom. All right, so it's important that we educate. Some of the risk factors for wound infections are obesity, diabetes, for obvious reasons. Obesity, a lot of times women have a pendulous abdomen that'll cover the incision, and moisture, which breeds bacteria, causes the infection to occur. Malnutrition, of course, can cause an infection because the body doesn't heal at the rate that it should. If they're on corticosteroid therapy, this also increases their chances of wound infection, and hopefully this doesn't happen, but poor suturing technique can also happen. And remember, this is when we assess for reta, redness, ecchymosis, okay? Edema, and discharge. Do they have any discharge? And the approximation of the wound. Remember reta, R-E-E-D-A. The physician might order a culture of specimen from the wound or the laceration. All right, and they will probably go on antibiotics, and they should apply warm compresses to the area. And of course, once they wash it with soap and water, they should maintain it dry. We have other complications that can occur. And then, of course, that is the onset of severe hypertension in the postpartum setting, which means, what is it by definition? It means the systolic pressure becomes greater than or equal to 160. And the diastolic is equal to or greater than 110, all right? Both require urgent antihypertensive therapy, all right? It's not necessarily to normalize it and bring it back to, let's say, 110/70, but to bring it down from that very high range of 160/110 to maybe 140, 150/90 to 100. So to decrease it, but not necessarily to normalize it. The other thing is the management of postpartum patients who have diabetes. Okay, it's important to know that insulin requirements for pre-gestational diabetic women decreases in the immediate postpartum period. All right, with oral intake of subcutaneous insulin, doses can resume. Gestational diabetes, okay? Although carbohydrate intolerance of gestational diabetes frequently resolves after delivery, up to 1/3 of the affected women will have diabetes or an impaired glucose metabolism in the postpartum screening. All right. And it's also been estimated that up to 50% of those women who develop GDM will develop type 2 diabetes later on in life. Postpartum follow-up. What is postpartum follow-up all about? It's basically about educating the patients and their families of things to report to the healthcare provider. In this case, we're talking about mom. We want to make sure that she knows that she should contact her provider if she develops fever, foul-smelling lochia, large blood clots the size of a golf ball or bigger, bleeding that saturates a pad every hour, if they have discharge, erythema, or severe pain for an incision, hot, red, painful breast, bleeding or severe pain in the nipples or breasts, severe headaches or blurred vision, because remember, we can develop preeclampsia in the postpartum setting if they have shortness of breath without exertion or chest pain, frequent painful urination, and definitely signs of depression. They must notify their physician. Speaking of depression, psychological complications that can occur, we have what we know as the famous or infamous baby blues. All right, the postpartum blues usually disappear without medical intervention, and they occur within the first 2 weeks postpartum. And women who have postpartum blues are still able to take care of themselves and the baby. They just feel a little sad, maybe a little bit sensitive. They watch something on TV and they get sensitive about it, but it's no big deal. Postpartum depression, on the other hand, requires psychiatric interventions, and it occurs within the first 12 months postpartum. So if you have baby blues and 2 weeks later you're still feeling a little sad and maybe a little sadder, and a month later you're still depressed, and 2 months later you're still depressed, you need to seek help. And it's important that we educate the significant others to be able to identify this, okay? If you no longer are able to care for yourself, like, you have to tell a significant other, if she is usually nicely, groomed and clean, and you get home and you find her and she hasn't even showered, she's a hot mess, the baby has milk on their clothes, or, look dirty, look like they haven't bathed, she doesn't look like she's brushed her teeth or her hair, you need to make sure that you address it and that you call the provider and let them know what is going on. Then we have a further complication of this is postpartum psychosis. Please note, it is a variant of bipolar disorder, and it is the most serious type of postpartum mood disorder. Okay, this is relatively rare, but it only happens in 0.1% to 2.6 per 1,000 births. However, the onset of symptom is rapid and can occur as early as 2 to 3 days after childbirth. Okay, and this is not like, oh, I'm sad. No, no, no. These people start hearing voices. Okay, they have bizarre delusions, usually associated with the baby. They have extreme mood swings. They're agitated. They could be depressed or they could be elated. They have distraught feelings about the ability to enjoy the infant. Their thought process is confusing. They have strange beliefs, and they start thinking, oh my gosh, the baby has to die, or I have to die, or all of these awkward behaviors. This may require hospitalization to the psychiatric unit for evaluation. They generally get placed on antidepressants and antipsychotic drugs, psychotherapy, and many times, sadly, electroconvulsive therapy. There's also what we call paternal postnatal depression, okay? That actually occurs in 1 to 8% of new fathers, and it can happen during the first 6 months after the delivery of the baby, okay? So basically what happens is, this is actually happening to the man. His testosterone levels are decreasing and the estrogen levels are increasing. Okay, lower levels are linked of testosterone in men are linked with depression. Okay, this is what we call PPND, paternal postnatal depression. Many times this goes underdiagnosed or untreated because the man or the healthcare provider fails to recognize the signs of this type of depression, or they lack the guidance for identifying this condition. So now we have to educate our parents too and let them know, you know what, mom, dad can also go into depression. So you have to watch them. Men tend to downplay the degree of the symptoms because they never want to admit that anything's wrong, or they don't want to go to the doctor, but we must be able to identify it. So again, you teach the relatives, those people that are close to them, so that they're able to identify if these issues are going on. Then we're going to talk about the high-risk neonate. Okay. So basically, one thing that it's important to know is that infant mortality rates in the U.S. have significantly decreased from 47 to 1,000 live births in 1940 to about 5.8 per 1,000 in 2014. So that is a huge drop. All right. And this is due to a lot of the, science, technology, and medications that we have. So high risk neonates, who is at high risk? Preterm neonates, okay? Being born before you're fully developed, or, at full gestational age, 38 weeks or above, can cause an array of complications. Please note that there are varying degrees of prematurity. You have what we call very premature, which is a neonate born before 32 weeks gestation. Then you have just premature, which is between a baby who's born between 32 and 34 weeks gestation. And then we have a late premature, which are babies born between 34 and 37 weeks gestation. Okay. The population with the largest percent of premature births are non-Hispanic Blacks. Just FYI. Common complications. The other thing that I want you guys to know is what the difference is between low birth weight. Low birth weight means the baby weighs less than 2,500 grams. Very low birth weight means less than 1,500 grams. And then extremely low birth weight means less than 1,000 grams. Common complications related to prematurity are respiratory distress syndrome, retinopathy of prematurity, hence the name, bronchopulmonary dysplasia, patent ductus arteriosus, periventricular, intraventricular hemorrhage, and necrotizing enterocolitis, which we're going to talk about a little bit more. Some of the risk factors for preterm labor and birth are some are modifiable, some are non-modifiable, right? So the non-modifiable is if the mother has a history of preterm labor or birth, you can't modify that. It is what it is. She already had a preterm birth, but it does put her at a high risk for having another preterm birth. If they've had multiple abortions, your race and your ethnic group are obviously non-modifiable factors. And like I said, non-Hispanic Blacks have higher rates of preterm births. Polyhydramnios, oligohydramnios, PIH or pregnancy-induced hypertension, placenta previa, exposure to DES. Remember, this is not told in the US anymore. Placenta abruption. If you have a parity, meaning you've delivered 0 babies or more than 4 babies. So no babies or more than 4. And then premature rupture of membranes. Modifiable factors are the age at pregnancy, which means you can decide whether you want to be pregnant or not. Okay, so that's huge. Things like low educational level, being single, unplanned pregnancy, poverty, domestic violence, life stress, obesity, low pre-pregnancy weight, incompetent cervix. These are not necessarily modifiable, but treatable. All right, so an incompetent cervix, it's not that the patient can do something about it, but the physician can. They can perform a cerclage. Remember that. If you have an infection, you can definitely treat it. If it's not treated, yes, it'll lead to preterm labor. Medical management. Lung maturity is generally determined by the lecithin and sphingomyelin ratio, or the Ellis ratio, much easier to say. So a lot of times they will measure that, but what they usually do, if they know that mom is going into preterm labor, they will administer corticosteroids, usually betamethasone or dexamethasone, and while the mom is still pregnant. And the reason why they do that is because it helps to mature the fetal lungs. Okay. You, as a nurse, if you have a mom who is in, preterm labor, you want to make sure that you review the prenatal, intrapartum, and neonatal histories. All right. Why do you want to know mom's prenatal history? Because you want to know, what did she do? Does she have hypertension? Does she do drugs? Does she have an infection that was untreated? Is this baby a preterm baby because mom had undiagnosed incompetent cervix? What is going on, right? Very important when we are caring for a premature baby is that you assess for signs of respiratory distress. What are the signs? This is important for you guys to know. Grunting, flaring, retracting, and cyanosis are signs for respiratory distress, and then we must provide respiratory support accordingly. It's also important that we maintain a neutral thermal environment. You want to keep your baby dry so that they don't lose heat through evaporation. You want to keep the head covered to prevent heat loss due to radiation and convection. Sometimes we use plastic barriers. When we have really, really premature babies, we wrap them in plastic to prevent heat loss and transepidermal water loss. Okay, this is for really preterm babies. And then we can also use a chemical warming mattress in order to maintain the thermal environment for the baby. You want to definitely assess the cardiovascular system of a premature baby, the murmurs, pulses, capillary refill. Provide cardiovascular support, assess responses to the different interventions, and then you want to maintain fluid and electrolyte in balance, monitoring INOs, restricting fluids as per orders, adding humidity to the neonate's environment to decrease water loss can also help, all right? Meet the neonate's nutritional requirements. And then if they're very preemie and they can feed on their own, make sure that you're utilizing the proper technique for gavage feedings. So what is the proper technique? Okay, you want to make sure that you utilize before you even do that, okay, you need to make sure that you're checking for the presence of bowel sounds. Assess the abdomen for bowel loops or discoloration. Measure the abdominal girth. Check for gastric residuals by aspirating the stomach, okay, with a syringe. The stomach content, with a syringe. You want to assess for emesis, stools for occult blood. Check the stools for substances. So the procedure for gavage feeding is to utilize a 5 to 8 French feeding tube. For the orogastric route, measure the tube from the mouth to the ear and from the ear to the lower end of the sternum of the baby. For a nasogastric route, make sure that you measure from the nose to the ear and from the ear to the lower end of the sternum. Check for proper placement of the tube, each insertion and before each feeding by injecting a small amount of air into the tube with a syringe while listening to whooshing or gargling sound with the stethoscope placed on the neonate's abdomen. So when you push in the air, if it is in the right place, you're going to hear gurgling. You have to assess it with a stethoscope, all right? Use tape to ensure that the tube is secured. Check for residuals before starting and feeding by aspirating the stomach contents with the syringe, and note the amount, color, and consistency of the contents. Feedings may be given by gravity or placed on a pump over 30 to 60 minutes. And then in some cases, continuous tube feedings may be ordered to remove the feeding tube. Pinch it closed and remove it swiftly. So you don't have to do it gently. You just pull quickly. And then assess the neonate for feeding intolerance throughout the feeding. It's also important that we try to transition the neonate from tube feeding to oral feedings as quickly as possible. All right. Supporting breastfeeding. This is important. We know that breastfeeding is beneficial for both baby and mom, and administering, of course, medications as needed. Then we have what we call kangaroo care. This is important for medically stable neonates that we perform skin-to-skin contact with the parents. All right, it is beneficial because it helps to decrease the risk of lower body temperatures, it reduces the risk of infection and pain perception. There's a lot of benefits of skin-to-skin care, okay? Of providing skin-to-skin, and then providing emotional support to the parents, involve the parent and the family in all aspects of the infant's care. When you have a neonate, your patient is not just the neonate, but mom, dad, and whoever, the significant other, or the family member, whoever is there. RDS, respiratory distress syndrome. Okay, it's basically a life-threatening lung disorders. Okay, and this is common in babies who are born prematurely because they have underdeveloped alveoli and insufficient levels of surfactant. Right? This is why These babies many times require surfactant. Okay, so the combination of the alterations of all these things can lead to atelectasis. The incidence of RDS affects 90 to 98% of all premature infants born at less than 28 weeks gestation. So these are like extremely premature babies. Pulmonary surfactant, please note, is composed of 90% phospholipids and 10% proteins, and it reduces the surface tension within the lungs and increases pulmonary compliance. Okay, surfactant the production of surfactant begins at around 24 to 28 weeks, and then it continues all the way until the baby is term. Okay, again, to check for the levels of surfactant, actually, or fetal lung maturity, we check the LS ratio and the PG, or the phosphatidylglycerol, right, to check whether lungs are mature or not. Some complications of RDS are PDA, patent ductus arteriosus, a pneumothorax, bronchopulmonary dysplasia, pulmonary edema, hypotension, anemia, oliguria, hypoglycemia, retinopathy of prematurity, seizures, and intraventricular hemorrhage. So as you can see, RDS could be the catalyst for an array of complications. You're going to find in a baby who has RDS, respiratory distress varies obviously depending on how premature the baby is. They'll have difficulty breathing, shortness of breath, tachypnea, which means the respiratory rate greater than 60 breaths per minute in a neonate. Intercostal, subcostal, or substernal retractions, audible expiratory grunting, nasal flaring is going to be visible, increased oxygen levels to maintain PaO2. The skin color will become gray or dusky. The breath sounds and auscultation are decreased. Rales are present as RDS progresses, so they'll start having fluid in the lungs. The neonate will become lethargic and hypotonic. An X-ray exam is going to show reticulogranular patterns of peripheral lung fields or air and bronchospasms. Hypoxemia may occur, acidosis, and tachycardia. So these are all signs and symptoms of RDS. Important to know about the surfactant therapy. Natural surfactant comes from a cow, a pig, okay? And the ones that are natural surfactants are called Survanta, Curosurf, or Infasurf. Then we have synthetic surfactants such as Exosurf, all right? Both of them reduce the tension of the alveoli and they prevent respiratory collapse during expiration, and they enhance the lung compliance. Okay, so babies with RDS, meconium aspiration, or persistent pulmonary hypertension generally will get some sort of surfactant, which is administered via an endotracheal tube. Okay, endotracheal tube. Some adverse effects of surfactant could be bradycardia, decreased oxygen sat, tachycardia, reflux, gagging, cyanosis, and then blockage of the endotracheal tube or hypotension. But there are a lot of benefits, all right? Then we have what we call bronchopulmonary dysplasia, or BPD, and it's a chronic lung problem that affects babies that have been mechanically ventilated or on oxygen for problems with RDS. So again, it's a complication of RDS. So remember, we want to make sure that we prevent RDS to then be able to prevent all these other complications. Long-term outcomes, in addition to long hospitalization stays and long-term oxygen therapy, they can develop cerebral palsy, retinopathy of prematurity, and hearing loss. Some of the risk factors for BPD are prematurity, RDS, and then oxygen toxicity, intubation, assisted ventilation with positive pressure, and then lower gestational age and birth weight, usually when babies are less than 32 weeks. With bronchopulmonary dysplasia, the treatment is really support and time. We just have to let the body repair itself and allow the baby to mature on its own. Okay. The patent ductus arteriosus, all right? This occurs when the ductus arteriosus remains open after birth. Remember, the PDA or I'm sorry, the ductus arteriosus should close when the baby takes its first breath because of the pressure changes. It should close. Sometimes it could take a couple of hours and it's okay, but in this case, it doesn't close when it should or during that time frame. So normally this closes within a few hours after birth, but it can take as long as 96 hours. The incidences of PDA in neonates is usually 1 in 2,000. All right, it occurs in 45% of neonates who weigh less than 1,750 grams, or in 80% of neonates that weigh less than 1,200 grams. Some of the complications resulting from PDA are congestive heart failure, chronic lung disease, or renal failure, NEC, which is necrotizing enterocolitis, and then even intraventricular hemorrhaging. With these babies, you're going to hear a heart murmur. You could hear a widened pulse pressure with decreased diastolic blood pressure. They could have tachycardia, tachypnea, recurrent apnea, bounding pulses. In a chest x-ray exam, you might see increased pulmonary vasculature. All right. So many times this has to be surgically repaired. You have to get, diagnostic tests such as an echocardiogram. They may be placed on diuretics. A cardiologist has to obviously assess the baby, and then they would have to do a surgical ligation. Okay. Intraventricular hemorrhage, all right? IVH occurs at the germinal matrix tissue surrounding the lateral ventricles of the developing brain, and they occur among premature neonates or those who experience RDS or complications associated with ventilation such as pneumothorax, hypercarbia, and acidosis, all right? So again, risk factors: prematurity, amniotic fluid infection, perinatal asphyxia, RDS, increased arterial blood pressure. If they have low APGAR score at 5 minutes, maternal general anesthesia, if mom received general anesthesia, which remember it's not common in OB. If they're low birth weight, if they have acidosis, and then what you're usually going to see is like decreased hematocrit, full or tense anterior fontanelle. Remember, ICP, intracranial pressure. When you have like a bulging fontanelle, that means increased intracranial pressure. You might be able to see hyperglycemia. Okay, and if the bleeding is worsening, the baby will develop apnea, a drop in blood pressure, acidosis, seizures, and then again, full tense and rapid increase in the head size. You have to make sure that you take the size of the head, that we measure the head, so that we know if this is getting worse, if hemorrhaging is increasing. Then we have NEC, or necrotizing enterocolitis. It basically results in inflammation and necrosis of the bowel, usually proximal to the colon or the terminal ileum, and it usually happens after enteral feedings. Okay, so this is why it's common in premature babies, because they can't breastfeed, they can't bottle feed, they have to have enteral feedings, and which makes them predisposed to NEC, necrotizing enterocolitis. 90% of NEC cases are among preterm neonates for that same reason. And causes of the intestinal ischemia or asphyxia include hypotension, hypoxia, stress, low body temp, hypovolemia, polycythemia, or a PDA. Remember, a PDA can lead to NEC. And remember what leads to a PDA? RDS. So again, it's like a little domino effect. With necrotizing enterocolitis, a lot of times they have to do a resection of the bowel, all right, to remove the necrotic bowel, and the baby will have a temporary colostomy bag. Retinopathy of prematurity, or ROP, also common in premature neonates or those with low birth weight. And it occurs because the retina is not completely vascularized when these babies are born so prematurely. All right, and they're more susceptible to stress and injury as a result of that, immaturity itself. Prolonged hyperoxia, meaning exposure to high level of oxygens, is also one of the risk factors, not just prematurity. Steroid exposure, if the baby has experienced sepsis or an infection, a PDA. intraventricular hemorrhage or blood transfusion. Maternal diabetes, bleeding, smoking, and hypertension are also risk factors for ROP. Post-maturity or post-mature neonates. These are babies who are born after 41 weeks gestation. All right, and some of the risk factors for this, for having babies who are born after the 41 weeks, is anencephaly, history of postterm pregnancies, if it's a first pregnancy, and grand multiparous women. So women who've been pregnant a lot of times, have had a lot of babies, they can, go into past the 41 weeks and have a post-mature neonate, all right? These babies, because the placenta function is decreasing, the placenta is usually becoming calcified, it's no longer able to meet the nutritional demands or oxygen demands of the baby. So it increases the risk for hypoxia and hypoglycemia at the onset of labor, okay? The result of these babies might be a neonate who's large for gestational age, or LGA, and then of course macrosomic, meaning weighing more than 4,000 to 4,500 grams. And then the chances of that happening increase as the pregnancy is prolonged. All right. Complications of these post-mature babies are meconium aspiration, because I already told you they're overdue. Okay, they've been in there for too long. Their bowels are working, everything's working, so they'll pass meconium in utero, and so it increases their chances of developing meconium aspiration. Fetal hypoxia related to the placental insufficiency, and then neurological complications, including seizures due to fetal asphyxia during labor or alterations in oxygenation. Hypoglycemia, again, related to the alterations in the nutrient transport due to the calcified or old placenta. Hypothermia can occur related to loss of the subcutaneous fat, that brown fat. All right, as they get older, it's not enough to thermoregulate the baby. What are you going to find in babies who are post-mature? And this is important. You're going to have dry, peeling, cracked skin. Okay, you're going to find lack of vernix, because remember, vernix occurs earlier on or when they're premature. Profuse hair, long fingernails. They might have a thin, wasted appearance. So they might be really long because they're growing, but they become wasted because, again, of the placental insufficiency. Meconium staining, all right, which is green or yellow staining of the infant's skin, nail beds, or umbilical cord. Hypoglycemia and poor feeding behavior. You want to make sure that you're assessing the neonate for any signs of hypoglycemia, which is jitteriness, irritability, poor feeding, apnea, grunting, and lethargy. Provide early and frequent feedings if respiratory status is stable, and you want to monitor the INOs on these post-term babies. Meconium aspiration, which is a syndrome that can cause respiratory failure in term and post-term neonates. Some babies, again, like I said, pass meconium when they're in utero, and when the baby's born, they will aspirate this. This sometimes can occur when there's a relaxation of the fetus anal sphincter due to fetal asphyxia. Again, domino effect. So we need to make sure that we know that. Then we have what we call small for gestational age and intrauterine growth restriction, right? Babies that are too small. Let's say you deliver a 35-weeker, but when the baby's born, it's really measuring the size is consistent with maybe a 30-weeker and not a 35-weeker, all right? Intrauterine growth restriction, it basically means the neonates are not consistent with the gestational age, and it might be affected due to, an array of things. And there's different types of IUGR. You have the symmetric IUGR, and you have the asymmetric IUGR, where you have a disproportional reduction in the size of structures and organs, resulting from maternal or placental conditions that occur later in pregnancy and impede placental blood flow. Contributing factors to IUGR, on the maternal side, it'll be multiple gestation, primipary, grand multipary. If they're younger than 15 years of age or older than 45, when they haven't had prenatal care, socioeconomic status, poor nutritional status, if they smoke or do any kind of drugs, if they have cardiac disorders, renal disorders, chronic hypertension, preeclampsia, anything related to the blood pressure can lead to IUGR. Remember, when we have high blood pressure, our vessels are constricted. And what happens is, as you constrict those vessels, the nutrients that are going through the placenta to the baby are not the same as somebody who doesn't have this type of issues, okay? If mom has phenylketonuria, that's another risk factor. Medications that she might be on can lead to IUGR. In the fetus, the female sex, they tend to be more likely to develop IUGR. Discordant twins, congenital anomalies, chromosomal syndromes, congenital infections, rubella can actually lead to IUGR, just like toxoplasmosis and cytomegalovirus, okay? With the placenta, of course, if mom has a small placenta, placenta is compromised in any way, shape, or form. If you have an abnormal cord insertion, if you have a previa, a chronic abruption placenta or placental hemangiomas can lead to IUGR. Then we have the opposite issue, LGA, large for gestational age. These are babies that are larger than 90% of the other babies, of their same gestational age. Some risk factors for having LGA babies are maternal diabetes, multiple previous macrosomic babies, and then prolonged pregnancy. Remember, so when we have those post-mature babies, or if mom is the diabetic, she's more likely to have an LGA baby. What happens with LGA babies? A lot of times mom cannot deliver vaginally and has to end up in a cesarean section because she's not able to deliver. For example, if you have a 12-pounder or a 13, 14-pounder, that would be very difficult to deliver vaginally. And sometimes when they deliver vaginally, they required operative vaginal deliveries, which increases the chances of developing shoulder dystocia or having the complication of a shoulder dystocia, all right? Birth trauma. CPD, cephalopelvic disproportion, because the pelvis is probably good enough for a normal sized baby, but not one that's, 4,500 grams. Hypoglycemia and hyperbilirubinemia are common in these babies. Hyperbilirubinemia, what is that? It's increased levels of bilirubin in the blood, and it affects more than 60% of term and 80% of preterm neonates, okay? You have two major forms. You have unconjugated and conjugated. So the unconjugated basically deposits into tissue and cross the blood-brain barrier. That is unconjugated bilirubin, okay? Conjugated bili is bound to albumin, and once bound, it is water soluble. It's non-toxic and can be excreted by the neonate, okay? So when we put a baby, let's say under a bili blanket, we're trying to convert the unconjugated to conjugated bili so that the baby can excrete it. So, because it cannot be excreted until it is conjugated. When serum bilirubin levels are greater than 5 milligrams per deciliter, the neonate is going to exhibit signs of jaundice. So you'll see the nose has a yellow hue, the chin, the eye, the sclera of the eye sometimes will have a yellow hue. And it basically starts at the top and it moves its way down. As it progresses or as it becomes more severe, the body, starts turning yellow. So it goes from the top to the bottom. A complication of hyperbilirubinemia is what we call kernicterus, okay, which is an abnormal accumulation of unconjugated. Remember, unconjugated is the bad one because it cannot be excreted. Unconjugated bilirubin and in the brain cells, all right? We want to prevent this, okay? How do we prevent it? Through early detection of hyperbilirubinemia. If we are not able to prevent kernicterus, this will result in brain damage, okay? So it's important that we know that. Please note that physiological jaundice results from hyperbilirubinemia that commonly occurs after the first 24 hours of birth, okay, or during the first week of life. And then we have pathological jaundice, okay, which results from various disorders and exacerbate physiological process that leads to hyperbilirubinemia in the newborn. Okay, such disorders can result in pathological unconjugated or conjugated bilirubin. Again, the conjugated, the baby can excrete. So we sometimes have to give them, if they're breastfeeding and it's not enough, we want to start giving them formula to be able to to be able to excrete the conjugated bilirubin. All right. With the management of hyperbilirubinemia and a healthy term or near-term neonate, okay, if they are less than 24 hours of age, we kind of just let them be. When they're more than 25 hours of age, or up to from 25 to 48 hours, if they have a bili of greater than or equal to 12, we want to consider phototherapy. Okay, if it's greater than 15 at 25 to 48 hours of birth, you definitely want to give them phototherapy. So the older they get, that number goes up. For example, at 49 hours, from 49 to 72 hours after the baby has been born, if their bilirubin is 15, you want to consider phototherapy, okay? If it is 18 or greater, then you must give them phototherapy. After they're 72 hours old, we would give phototherapy mandatorily if it's above 20, and we might consider it if it's above 17. Remember, early detection and treatment decrease the risk of developing bilirubin encephalopathy. So we use things such as a fiber optic blanket, also known as a bili blanket. All right, and it's basically connected to a power source. It's wrapped around the bare torso of the infant. The baby cannot have clothes on. Usually we put a diaper on and that's it. All right, and it remains on the infant for 24 hours, and the parents can hold the feeding infant while the blanket is in place. Blood tests to assess the bilirubin levels are used to determine the effectiveness of the therapy. So in babies who are receiving phototherapy, okay, the lights should be positioned 18 to 20 inches away from the infant. And this is when using fluorescent lights, right? Or about 2 inches away from the top of the incubator. Okay. Feedings must occur every 2 to 3 hours. They're important to provide adequate fluid and to compensate for the insensible fluid loss that promote the excretion of the bilirubin. So it's important that babies are fed. We want to cover the eyes to prevent damage, so they usually put a little eye cover on the baby. It's important to do that. Then we have infants of diabetic moms, okay? We know what diabetes is, and it is sometimes associated with poor outcomes of the baby. Why? They can have complications due to the high levels of glucose during pregnancy, such as cardiac anomalies like transposition of the great vessels, ventricular septal defect, left to right ventricular wall hypertrophy. They can have skeletal defects, small left colon syndrome, IUGR, neurological damage and seizures related to the inadequate glucose supply to the brain of the neonatal due to neonatal hyperinsulinism. Risk of childhood obesity and type 2 diabetes are also possible complications. Okay. So we want to assess for complications of maternal, due to the maternal diabetes. These babies, a lot of times, remember, will be macrosomic, so much bigger than 4,000 to 4,500 grams. You want to make sure that you assess the clavicles or brachial nerve damage, because if they were macrosomic babies, they probably had traumatic deliveries. Even in a C-section, when you have a baby that is really large, it could be difficult and traumatic for the baby and therefore cause all these complications like brachial nerve damage or clavicle, of fractured clavicle. Hypoglycemia, we know that. Hypocalcemia and hypomagnesemia is also common. Polycythemia, hyperbilirubinemia, low muscle tone, poor feeding abilities, and RDS are some of the findings for these babies born to diabetic moms. Infections in the neonates, okay? This is generally due, it's actually among the leading cause of morbidity and mortality in the neonates. And sometimes it could be due to things such as GBS. It is important, okay? It's actually the primary cause of neonatal meningitis and sepsis in the US, All right, all pregnant women are asymptomatic carriers of GBS, which is found in the genital and lower just gastrointestinal tract. I'm sorry, I'm like dry already from talking. Anyway, evidence supports the use of antibiotics during labor. All right, it has to be penicillin or ampicillin for it to be truly effective. And when labor starts, we want to administer these medications every 4 hours until delivery. Please note, all women are routinely screened for GBS at 35 to 37 weeks gestation. So when your patient comes in, you should know whether she's GBS positive or not. If she is, you want to treat it with antibiotics. If a patient comes in, let's say at 34 weeks, where she hasn't been assessed for GBS, we treat it prophylactically. Why? Because while the mom can go asymptomatic, okay, for the baby, it can be detrimental, all right? They can develop sepsis, meningitis, and a ton of complications, respiratory issues as well. So we want to make sure that GBS is treated, all right? Signs of neonatal infection. How do we know a baby has an infection? Okay, respiratory. What is the respiratory system going to be doing? The baby might develop apnea, grunting, retractions, tachypnea, or cyanosis, which we know can also be signs of respiratory distress. But remember, with babies, it's like domino effect. One thing can lead to another, to another, to another. Thermoregulation will be difficult in babies who have infection. They might have a fever, or they might have hypothermia, or temperature instability, where the blood pressure, the temperature goes up and down, and we don't know what's going on. The baby can develop arrhythmia, hypo or hypertension, and decreased perfusion. Neurologically, the baby can develop tremors, lethargy, irritability, high-pitched cry, hypertonia, hypotonia, seizures, and bulging fontanelles. Please note that to be a NICU nurse, you have to have excellent assessment skills, because your patient doesn't speak, and a lot of the conditions have the same signs and symptoms. So you have to look at your patient holistically. What was the prenatal care? Was mom GBS positive? Was mom a drug user? Did she receive treatment for her GBS? Did she not? Does she have allergies to penicillin? Because it means she received another antibiotic to treat GBS, which is not 100% effective. Does my baby require antibiotics? Okay. Then we have those moms that have substance abuse issues. So we have babies that have been exposed to substance abuse. Please know that 15.9 or almost 16% of pregnant women smoke cigarettes during their pregnancy. 8.5 drink alcohol, and 5.9 use illicit drugs and cannabis. The number of heroin users has increased significantly over the last 10 years. Okay, so it is necessary that we keep our eyes open, because a lot of these patients, they're not going to come in and tell you that they do drugs, and we don't necessarily do a tox screen on every single patient. If we don't suspect or think that she is doing any kind of illicit drugs, we do not do a drug test. Neonatal abstinence syndrome, or NAS, is a group of signs and neurological behaviors that are exhibited by neonates, resulting from the abrupt discontinuation of intrauterine exposure to whatever substance the mother was addicted to or utilizing during pregnancy. Okay. Some of the signs of neonatal withdrawals in babies who have been exposed to an array of drugs in utero are apnea, behavior irregularities, diarrhea, excessive crying, excoriated skin, fever. High-pitched cry is a big one. Hyperreflexia or hypertonia, lacrimation, nasal congestion, poor feeding, seizures, skin mottling, sleep problems, sneezing, sweating, tachypnea, tremors, vomiting, wakefulness, weight loss or failure to gain weight, and yawning. All of those are signs and symptoms of neonatal withdrawals. There are a lot of details in terms of what kinds of signs and symptoms are caused by the different drugs. Then we also have to talk about the different common congenital anomalies. There is a ton of them, all right? But common congenital anomalies, we have diaphragmatic hernia, which basically is herniation of the abdominal organs through a hole in the diaphragm through into the thoracic cavity. All right, how do we treat it? Gastric decompression. We want to stabilize the baby, and then they would require surgical repair. The other one that is cleft palate or cleft lip, requires surgical repair. Spina bifida, meningeal seal or myelomeningeal seal. Okay, what is this? It's a sac with the meninges and cerebrospinal fluid bulge through the defect in underdeveloped vertebrae. Okay, these are the babies. When we look for the hair tuft above the buttock, okay, the hair tuft, or if we might have a sac that's actually out. When you have myelomeningeal seal, that sac actually holds meninges and nerve tissue, all right, because we have a spinal column defect. There is no spinal column there, let's say, so it bulges out, it comes out and you can see it. It has to be surgically repaired. Some of the nursing interventions with these babies is to make sure that you cover the sac with a sterile, moist gauze, because you want to keep it clean and you want to keep it moist. You would never lay a baby who has myelomeningeal seal on their back. You would have to lay them on their belly and monitor them closely, because remember, babies are supposed to go back to sleep. They should be sleeping on their back. However, with myelomeningeal seal, this is not possible, because if you do not want to apply pressure to that sac. It has nerve endings, so it is critical that it remains intact and that the baby, if you put on a diaper, that you're not touching, and the baby is kept clean at all times to prevent that from being exposed to any type of fecal matter or urine. Anencephaly, we know it's incomplete formation of the cranium and of the brain. Most babies die within a few days of birth. This is what we were concerned with, Zika, okay, anencephaly. Then we have polydactyly. Polydactyly means that they have extra digits on the hands or foot. And syndactyly means that all the digits are fused together, whether it's on the hand or the feet. And they can have it surgically fixed. In the case of polydactyly, when they have extra digits, if it's literally just tissue, they would do a ligation. So they tie it up and it falls off on its own. If there is bone, the parents can choose to surgically have it removed. And then with syndactyly, surgery depends on the extent of the anomaly. Okay, it's important that you guys also know about tetralogy of Fallot. What is tetralogy of Fallot? It basically is it's a compilation or a combination of different defects. Okay, so you have ventricular septal defect. You have an overriding aorta, pulmonary stenosis, and hypertrophy of the right ventricle. It has to be surgically repaired. All right, if it's going to be medically management, you have to do propranolol for cyanotic infants. Prostaglandin E1 may be administered to maintain a patent ductus arteriosus until surgery, and for infants with severe tetralogy of Fallot. With discharge planning, we know what to do. We need to tell mom, if your baby is oozing out of the umbilical cord stump, if they had a circumcision and it smells, we need to make sure that you notify the physician. All right. You also need to know what is the family's readiness to take that infant home. You have to make sure that you teach them about bathing the baby, feeding the baby, diapering the baby. How often should the baby be fed? If they're breastfeeding, it's on demand. If they're on formula, usually every 3 hours. Parents who are taking babies who are premature home should be taking a CPR, an infant CPR class before taking the baby home. Baby safety issues are important. Remember, they have to be on a rear-facing car seat until they're 2 years old or at least 20 pounds or whatever the manufacturer says. Baby should be going back to sleep, sleeping on their back. Okay. So it's important that we educate parents, particularly on these babies that are high risk. For loss and grief, parents who experience loss and their grieving process, okay? This is very difficult. They are going to go through different stages, the stages of grief. They first are in avoidance and disbelief, shock and guilt. Then they experience pain, physical discomfort, depression, difficulty concentrating, anger at themselves or at their partner. And then eventually they enter acceptance and adaptation, okay? Grief persists, but a sense of balance is achieved. You have to keep in mind that everybody experiences this grief in their own way, okay? And then, of course, culture, religion, their personal experiences and beliefs impact on how they will respond to the loss, okay? So you have to kind of roll with the punches and make sure that you are providing adequate support for the families. Allow them to grieve and express their feelings. Do not make the mistake of saying, oh, it's okay, you're still young, you're going to have another baby. No, because they could have 20 more babies, but it's not going to replace the one that they lost. Express empathy and your condolences, okay? Refer to the baby by name, okay? Or if they were unnamed, call it he or she. Provide information about the process of grieving and what to expect physically and emotionally. Refer the parents to community service and support groups that may assist in facilitating the grieving process. This is very important because they're with you for a very short period of time. However, like they said, grieving lasts for a very long time, and many people require a support group for a very long time after that. I have seen where parents are okay with it and they accept it because it's God's will. And I have seen parents who have, a 37-week baby perfectly formed, be born, lose the baby, and they don't grieve the same. Again, that has to do a lot with their personal experiences and how they view the world, and you just have to be there to provide the necessary support. I hope you enjoyed this, and I will see you next time.